We are live.
Good evening. Welcome to iFocus Lecture 155, Retina Module number 7. Today we have Dr. Pradeep Sagar from Sankara Hospital, Shimoga, continuing his talk on fluorescein angiography, part 2. He did part 1 on Friday, last week, on November 19th, which is available on YouTube. I request Dr. Lalit Verma to reintroduce Pradeep Sagar.
Thank you, Santosh, for this wonderful series on iFocus, which you have been doing a human service for the entire ophthalmic community, I would say. And I welcome once again Dr. Pradeep Sagar, an old colleague from RP Center, and he's doing wonderful work. Presently, he's a senior veterinary surgeon in Sankara, and post-graduation from our alma mater, RP Center, AIMS, and very privileged to have him here. He will tell us part 2 of angiography, and I believe first part was primarily on basics, and all of you must have taken some notes about what is angiography, novotony, always, and pseudo-fluorescence, hyperfluorescence, and all these things. But today the thrust, I believe, is primarily going to be application of all those knowledge, what Pradeep told in the beginning, to real-world disease entities, retinal diseases. And obviously, you can't cover the entire gamut because a lot of books have been written. So I am 100% sure that he will pick out common diseases. You see, angiography of late has taken a backseat with the coming up of OCT and now Octa also. But I still believe it still has a definitive role. You see, a couple of years back, we analyzed that angiography, what we used to do, say, a couple of decades back, the numbers have come down, but we still rely on FA in a lot of these diseases. Although we are tilting towards OCT for a lot of follow-up patients and Octa also, but angiography, I still believe, has a role. But everybody does not have Octa also. That also should be kept in mind. So this lecture is important because all of us face all these vascular diseases, diabetes, vascular block, ARMD, and so many other mechanisms, tumors, Coats disease. We still depend on angiography for disease. So I'll request Pradeep, without wasting much time, and he will have around good 40-45 minutes. And that the beauty of iFocus is we do give speaker enough time to explain all these things. And after that, we will have some chit chat, some questions from the audience, and some comments from Ajit, Babu, and very happy to see Gopal, Pillai also here, who has joined us. So over to you, Pradeep.
You can unshare. Rolika, please unshare the screen. Okay.
Thank you.
Good evening, one and all. Are the slides visible?
Yeah, please carry on. You are audible and visible both.
Thank you, sir. At the outset, again, I would like to thank iFocus, Santosh sir, and all the senior faculty members for giving me this opportunity to present my talk. I'll be continuing with the second part of my presentation on fluorescein angiography. Today, I will be mainly discussing the angiographic characteristics of the common retinochoroidal disorders. To begin with, the vascular disorders of retina and choroid. First, I will be discussing about ocular ischemic syndrome. We know that ocular ischemic syndrome is characterized by low flow through the ophthalmic artery. So, as expected, we can see that there is delay in choroidal filling. There will be patchy choroidal filling. Here we can see that there is an example. This is a fundus photograph, fundus fluorescein angiogram of 38 seconds, where we can see that there is patchy filling of the choroid. Here we can also see that there is a leading edge of dye. Again, here we can see that there is a leading edge of dye in the arterial tree. Normally, the leading edge of dye is not capturable in fluorescein angiography because the flow is usually faster. So whenever there is a slow flow, as in ocular ischemic syndrome and in central retinal artery occlusion, we will be able to see the leading edge of the dye. So in this case, we can see the leading edge of the dye and choroidal patchy filling. So whenever we come across a case in which we are suspecting ocular ischemic syndrome, such as a case with presence of neovascularization of iris, venous dilatation, and mid-peripheral hemorrhages, the diagnosis of ocular ischemic syndrome can be confirmed by fluorescein angiography. So moving on to diabetic retinopathy. In this fundus photograph, we can see that there is presence of a few microaneurysms, cotton wool spot, and this is the venous phase of the angiogram, where we can see that the foveal avascular zone is relatively preserved with presence of few dot hyperfluorescence at the margin of foveal avascular zone. We can see that the cotton wool spots and hemorrhage are seen as blob fluorescence, as we can see over here, whereas the microaneurysms are seen as dot hyperfluorescence. So we can differentiate a dot hemorrhage and a microaneurysm on fluorescein angiography. Here we can see that this is a dot hemorrhage, which is seen as a blob fluorescence, whereas microaneurysm is seen as dot hyperfluorescence. This is the late phase angiogram of the same eye, where we can see that there is increase in intensity and size of hyperfluorescence surrounding the microaneurysms. So, which is suggestive of the leaky microaneurysm here and here. So, in this eye, we can see that most of the leak can be attributable to the microaneurysms. So, we define it as focal leak. On fluorescein angiography, we classify the leak as focal, diffuse, or mixed. If most of the leak is attributable to microaneurysm, we call it focal leak. If the microaneurysms are not contributing to the leak, then we call it diffuse leak. If it's partly contributing, we call it mixed. So it's a case of non-proliferative diabetic retinopathy with focal leak, but we need to understand that we have to have all the fields to confirm whether it's a non-proliferative diabetic retinopathy alone, because it's possible that the posterior pole may not show any neovascularization, but it may be present in the mid-periphery. So moving on to a second case, here we can see that there is presence of few microaneurysms scattered all around the fundus, and we can see that the foveal avascular zone is relatively intact with minimal distortion inferiorly. The microaneurysms are very minimal compared to the previous case in the perifoveal area. But in the late phase angiogram, we can see that there is profuse leak in the perifoveal area with presence of petalloid appearance, which is suggestive of cystoid macular edema. As I previously mentioned, here the microaneurysms are not primarily contributing to the leak. So we prefer to call it a diffuse leak. So moving on to another case, here we can see that this is the color fundus photograph, which shows a streak pre-retinal hemorrhage and a few vascular abnormalities. On fluorescein angiography, this is the venous phase, where we can see that there is a minimal distortion of the foveal avascular zone, presence of few scattered microaneurysms, and blob fluorescence corresponding to the streak pre-retinal hemorrhage. Here we can see that there are multiple irregular network of vessels in the venous phase, which are crossing the major vessels. So here we can see that there's a network of vessels which is crossing the major vessel. And in late phase, we see there is a profuse leak from each of these irregular network of vessels. So it is suggestive of neovascularization. Here we can see that in the perifoveal area, there is leak, but on earlier frame, we didn't see much of microaneurysms. So this is again classified as a diffuse leak. So it's a case of proliferative diabetic retinopathy with diffuse leak at the macula. So the other findings we see in diabetic retinopathy include distortion of foveal avascular zone, which is suggestive of macular ischemia. Here we can see that the shape of the foveal avascular zone is altered, and again we can see that the size is significantly increased. The laser-induced chorioretinal scars are usually seen as in areas of central hypofluorescence with a rim of hyperfluorescence. In cases with proliferative diabetic retinopathy and severe non-proliferative diabetic retinopathy, we will be able to see the non-perfusion areas. As we can see, these are the areas of hypofluorescence corresponding to the non-perfusion areas. And here we can see that there is a vascular network which is connecting the artery and a vein, and it's not exhibiting significant leak. So it's a intraretinal microvascular abnormality, In contrast to neovascularization elsewhere, this is not crossing the major blood vessels. It doesn't have a profuse leak like neovascularization. So what are the indications of fundus fluorescein angiography in diabetic retinopathy? Earlier, probably a decade or 2 decades ago, diabetic retinopathy is an indication for fluorescein angiography, and most of the cases would have underwent fluorescein angiography. But in the current era, the number of cases undergoing fluorescein angiography is decreased. We can consider doing fluorescein angiography for establishing the exact stage of the disease at first visit. That's for the documentation purpose. So the other indication is in a patient with unexplained poor vision, in a patient with diabetic retinopathy, we may consider doing fluorescein angiography to rule out macular ischemia. As we can see over here, in this case, on fundus examination, there was no macular edema, there was no significant abnormality which can explain the poor vision, but fluorescein angiography showed a distorted foveal vascular zone which confirms presence of macular ischemia. Nowadays, OCTA is being used for establishing the diagnosis of macular ischemia than fluorescein angiography. So coming to the macular edema. So in macular edema, the current standard of care is intravitreal anti-VEGF therapy, but laser is still considered in cases with non-central diabetic macular edema, or it's used as a combination therapy with intravitreal anti-VEGF. So when we are doing laser for macular edema, we need to know a few things. One is we need to know whether it's a perfused edema or a non-perfused edema, which can be detected by fluorescein angiography. If it's a perfused edema, we need to identify whether it's a focal leak or a diffuse leak. If it is a focal leak, we need to identify the leaky microaneurysms and its relation to foveal vascular zone to decide on laser. I will be just describing the same. Here we can see that it's a perfused macular edema. That is, we can see that there is presence of leak in the perifoveal area. Whereas here we see that there is no perfusion at the perifoveal area. So it's a non-perfused macular edema. If a patient with macular ischemia and a non-perfused macular edema is planned for laser photocoagulation, then there is a significant risk of further worsening the condition. So in patients with non-perfused macular edema, macular lasers are avoided. So coming to the focal leak and diffuse leak. So here we can see that most of the leak is attributable to the microaneurysm. So it's a focal leak. In such cases, we consider doing focal laser photocoagulation to the leaky microaneurysm. Whereas in a case with diffuse leak, where there are no significant microaneurysms contributing to leak, we consider grid laser. So we have to identify which are the leaky microaneurysm, and we have to identify its relation to foveal avascular zone. Here we can see that there is a few microaneurysms which are non-leaky. We can see in the late phase, they are not exhibiting any leak. So these microaneurysms need not be lasered. So these are the leaky microaneurysms, but they are located within 500 micron from center of fovea. Again, it's a visually important area, so doing laser over here is again avoided. But these are the microaneurysms which are leaky and are away from macula, which are away from fovea, at least more than 500 micron away from fovea. So these are the microaneurysms which we can do focal laser photocoagulation. So the other indication is if there is a doubtful neovascularization. Here we see that there is a red lesion, but we are not very sure of neovascularization. But on fluorescein angiography, we can see that there is an irregular network crossing the major vessel with leak, suggestive of neovascularization elsewhere. Here we can also see that there is a leak over the optic disc, which is suggestive of a neovascularization at disc, which was not easily detectable on fundus photograph. So the other indication is in cases with asymmetric diabetic retinopathy. In some situations, we see a patient may have one eye severe disease, such as a proliferative diabetic retinopathy or an advanced diabetic eye disease, but the other eye may have a moderate or a mild non-proliferative diabetic retinopathy. In such situations, we consider fluorescein angiography to rectify whether the less severe disease is actually less severe or whether there are any neovascularization or there are any capillary non-perfusion areas which we have missed on clinical examination. So the other thing is a more severe eye may have an additional component of vein occlusion or an ocular ischemic syndrome. That would be the reason for it to be a more severe. That can be even identified on fluorescein angiography. Coming to asteroid halosis, in this case, we can see that there is significant asteroid halosis and there are a few dot hemorrhages, but we are not able to establish the status of diabetic retinopathy. But on fluorescein angiography, we can see that there is presence of perivascular leak. We can see that there are areas of capillary non-perfusion. There are a lot of microaneurysms, which helps us understanding the severity of diabetic retinopathy in this patient. Why this advantage? So in patients with asteroid halosis, if we are seeing the patient with the indirect ophthalmoscope, whatever the white light that we use, that is incident on the fundus, and most of the light is scattered by the asteroid halosis. Now what happens is like the whatever light that comes back to our eye is both the scattered light from the asteroid halosis and the light which is reflected from the fundus. The scattered light from asteroid halosis actually hampers the visualization of the fundus. Whereas in fluorescein angiography, we incident the fundus with blue light. Now, the blue light which reaches the fundus is observed by sodium fluorescein and fluorescent green light is emitted. Whereas the asteroid halosis scatters the blue light. Now, the scattered blue light from asteroid halosis and the fluorescent green light both move towards the camera, and the scattered blue light is filtered by the barrier filter. So only the fluorescent green light reaches the fundus camera, which takes the image. So the scattered light from asteroid halosis is blocked, and hence in asteroid halosis, fluorescein angiography gives a better view of the fundus. It's not just limited to diabetic retinopathy. In any case in which there is significant asteroid halosis and we are suspecting a condition which we can identify by fluorescein angiography, we can consider fluorescein angiography in those cases. So the other indication is to differentiate an Irwin gas syndrome from diabetic macular edema. We know that post-cataract surgery, the diabetic macular edema worsens, and at the same time, there is also a risk of developing Irwin gas syndrome. Which component is predominantly responsible for macular edema would be identified by fluorescein angiography. Here we can see that there is presence of disc leak in the late phase and petalloid appearance suggestive of cystoid macular edema, whereas here we can see that the disc is not leaking and there is petalloid appearance. So in this scenario, whenever there is a disc leak, it indicates that there is ongoing inflammation in the eye. So if we see a disc leak in such a scenario, it is probably due to Irwin gas syndrome. And if we don't see a disc leak, it is primarily due to diabetic macular edema. So to summarize, in diabetic retinopathy, fluorescein angiography will be considered for documentation purposes to rule out macular ischemia in patients with unexplained poor vision. If we are planning macular laser for macular edema, then to differentiate a perfused macular edema from non-perfused macular edema, to differentiate a focal leak from diffuse leak, and to identify the leaky microaneurysm and its relation to foveal avascular zone. In cases with doubtful neovascularization, to confirm the diagnosis. In patients with asymmetric diabetic retinopathy, to understand the cause of asymmetry. And in cases with dense asteroid halosis, to understand the status of the diabetic retinopathy. And in post-cataract surgery macular edema, to identify whether it's primarily Irwin gas syndrome or worsening of DME. So moving on to vein occlusions. Vein occlusions can be classified as central retinal vein occlusion, branch retinal vein occlusion, hemiretinal vein occlusion, or tributary vein occlusion, or macular vein occlusion. So coming to central retinal vein occlusion, in this fluorescein angiography image, we see that there is extensive hypofluorescence due to block fluorescence. It's an acute case of CRVO. In this case, by doing a fluorescein angiography, we are not getting any additional information. So fluorescein angiography is better avoided in acute vein occlusions until there is resolution of hemorrhages. Coming to this case example, here we can see that there is presence of cystoid macular edema, and we see a few cotton wool spots scattered all around the fundus. But we are not sure of the diagnosis. So on angiography, this is the venous phase of the angiogram, where we can see that there is slight distortion of the foveal vascular zone, a few areas of non-perfusion, and presence of multiple microaneurysm in a non-diabetic patient. In late phase, we can see that there is profuse leak in the perifoveal area with petalite appearance suggestive of cystoid macular edema, and we can also see that there is presence of perivascular leak, which indicates that this would be possibly a case of old central retinal vein occlusion with persistent macular edema. So this is another case in which we can see that there is tortuous vein and an altered reflex of the fundus. On fluorescein angiography, we can see that there is extensive areas of hypoperfusion and delay in venous filling, so suggestive of central retinal vein occlusion. Here we can see that the foveal avascular zone is significantly enlarged and distorted, suggestive of macular ischemia. So it's a case of ischemic central retinal vein occlusion with macular ischemia. In this case, in the late phase, we can see that there is leak in the peripapillary area, which correspond to a irregular vascular network in early phase, suggestive of neovascularization at disc. So it indicates that we have to consider a pan-retinal photocoagulation in this case. So in this patient, we can see that there are scattered flame-shaped hemorrhages in the superior half of the retina, mainly involving the macula and supranasal fundus. On fluorescein angiography, this is the venous phase where we can see that inferiorly the laminar flow is seen in the veins, but in the superior half of the retina, the veins does not show any filling, suggestive of a delayed filling in the superior half of the retina. So which is diagnostic of a hemiretinal vein occlusion. Here we can see that the retinal hemorrhages are corresponding to hypofluorescence due to block fluorescence, and we can also see that there is extensive non-perfusion areas in the superior half of the retina and an enlarged distorted foveal avascular zone suggestive of macular ischemia. So it's a ischemic hemiretinal vein occlusion with macular ischemia. Here we can also see that there is leak at the optic disc, which may be indicative of neovascularization at disc. Coming to another example, here we can see that there is presence of a sclerosed vein. Other than that, we see that there is an altered foveal reflex. On fluorescein angiography, we can see that there are multiple microaneurysms and vascular abnormalities which are confined to the superotemporal quadrant, which is indicative of a old superotemporal branch retinal vein occlusion. Here we can see that there is distortion of the foveal avascular zone, suggestive of macular ischemia. And here we can see that there is no leak in the foveal area. So it's a case of old superotemporal branch retinal vein occlusion with macular ischemia. So in vein occlusion, the indication of fluorescein angiography would be to document the disease process, to differentiate an ischemic central retinal vein occlusion from non-ischemic central retinal vein occlusion. It is helpful because the non-ischemic central retinal vein occlusion has a good prognosis and has lesser risk of development of neovascularization of iris. It also helps in identification of subtle neovascularization at disc. When we discuss about the other forms of retinal vein occlusion, like branch retinal vein occlusion, hemiretinal vein occlusion, and macular vein occlusion, it can be used for documentation purpose. And in cases with old branch retinal vein occlusion and hemiretinal vein occlusion, it is helpful in identification of a small neovascularization. For example, here we see that there's an hemorrhage, but we are not sure about a neovascularization. But on fluorescein angiography, we can see that there is presence of neovascularization and extensive non-perfusion areas, which is indicative of presence of a proliferative stage, and it needs a laser photocoagulation to ensure regression of these new blood vessels. So it's also helpful in identification of subtle macular vein occlusion. Here we can see that there is not much of a fundus abnormality other than a bending of a vein over here. But on fluorescein angiography, we can see that there is presence of microaneurysms and vascular abnormalities which are confined to the inferonasal aspect of macula, indicating that it's a old macular vein occlusion. So moving on to choroidal neovascularization. In patients with choroidal neovascularization, we describe lesion and 3 lesion components. The 3 lesion component includes the choroidal neovascularization itself, hemorrhage, and scar. If more than 50% of the lesion is composed of choroidal neovascularization, we call it predominantly CNV. If more than 50% is scar, we call it predominantly scar. If more than 50% is hemorrhage, we call it predominantly hemorrhage. So we classify choroidal neovascularization based on fluorescein angiography into a classic CNV and occult CNV. Classic CNV is located in the subretinal space, so the lesion can be seen very well. In occult CNV, it is located in the sub-RPE space, so the lesion will not be seen very well on fluorescein angiography. It is further subdivided as fibrovascular pigment epithelial detachment and late leakage of undetermined source. Again, CNV is classified as predominantly classic if more than 50% of the CNV is classic. It's classified as minimally classic if 0 to 49% of the CNV is classic, and if there is no classic component, we call it occult CNV. So coming to an example of classic CNV, here we can see that this is the arterial phase of angiogram where we see a well-defined vascular network and block fluorescence surrounding the vascular network corresponding to the subretinal hemorrhage. In late phases, we can see that there is profuse leak, that is increase in intensity of hyperfluorescent and size of hyperfluorescence with fuzziness of margin, indicative of a classic CNV. So in this patient, we can see that in the venous phase of the angiogram, there are not much findings. There is no definite vascular network, but at 40 seconds, we see that there is presence of stippled hyperfluorescent dots confined to the foveal and perifoveal area. And in the late phase, we can see that there is increase in intensity and size of hyperfluorescence around these dots, indicative of a fibrovascular pigment epithelial detachment. It's again an occult CNV with no classic. Coming to an example of late leakage of undetermined source. So this is the venous phase of the angiogram where we don't see any definite vascular network in the choroidal phase or in the arterial phase, and we don't even see stippled hyperfluorescence up to 1 minute. But in the late phase, we can see that there is area of leak at the fovea which cannot be attributed to a specific source, which is defined as a late leakage of undetermined source. So what are the indications of fluorescein angiography in choroidal neovascularization? So one is for documentation and confirmation of the diagnosis. Then to classify the lesion as predominantly CNV or scar or hemorrhage. To distinguish classic CNV and occult CNV. To note on fluorescein angiography, PCV is seen as occult CNV. And to assess CNV activity, that is whether it's leaking or not leaking. These are mainly helpful for research purposes. Clinically, it may be helpful in diagnosis of CNV in cases with subretinal hemorrhage. For example, here we can see that it's a myopic eye with presence of subretinal hemorrhage at the fovea. In myopic eyes, the hemorrhage can be, a subretinal hemorrhage can be due to a Lacquer's crack or due to development of a choroidal neovascularization. In this patient on fluorescein angiography, we can see that there is presence of a small network of vessel with leak in late phase, confirming the diagnosis of choroidal neovascularization. So this patient has to be treated with anti-VEGF. If it was just a lacquer crack related hemorrhage, we would have just observed the patient. Central serous chorioretinopathy. This is one disorder in which fluorescein angiography plays a very important role, and as of now, OCTA has not shown to be that helpful as fluorescein angiography. So here we can see that there is presence of subretinal fluid and there are 2 orange lesions suggestive of a pigment epithelial detachment. In this patient, in venous phase of the angiogram, we see that there is a dot hyperfluorescence which is increasing in size and intensity with fuzziness of the margin in the late phase suggestive of leak. This is an ink blot pattern of leak. We can see that from a small point, it is spreading circumferentially. So it's an ink blot pattern of leak. Other than that, here we can see that there are 2 areas of hyperfluorescence which are increasing in intensity, but the size is almost remaining the same, suggestive of cooling into a serous pigment epithelial detachment. So we discussed about the ink blot pattern of leak. This is another pattern of leak called the smokestack pattern. Here we can see that the leak spreads vertically upwards in a linear fashion, and in the late phase we can see that it spreads in a smoke-like appearance. So it's called smokestack pattern of leak. It is seen in around 10 to 16% of cases of acute CSC. Smokestack leak is common in first episode of acute CSC, and it is postulated to be due to the differential osmotic pressure of fluorescent dye and protein-rich subretinal fluid. It is also postulated that in cases with presence of RPE microrip, there is presence of smokestack leak. In cases with chronic central serous chorioretinopathy, it is seen as areas of mottled hyperfluorescence. We can see that there is presence of mottled hyperfluorescence in a tear shape. It's called gravitational tract or teardrop sign. So in chronic CSC, fluorescein angiography helps in confirmation of the diagnosis. With advancement in fundus autofluorescence, this kind of a picture is better seen in a non-invasive technique, and fluorescein angiography can be avoided in cases with chronic CSC for confirmation of the diagnosis. Fundus autofluorescence gives a similar good picture. So the indications of fluorescein angiography in central serous chorioretinopathy include confirmation of diagnosis in atypical cases like presence of fibrin, in cases with chronic CSC and multifocal CSC. The other indication is when the fluid is persistent and if we are planning for treatment to identify the point of leak and its relation to foveal avascular zone. Here we can see that the point of leak is away from the center of fovea, and we can consider doing a focal laser photocoagulation to achieve resolution of subretinal fluid. But if the leak is in the foveal area, focal laser is not a good option, and we may have to consider a half dose or a half fluence photodynamic therapy. So another example, a perifoveal telangiectasia type 2. Here we can see on fundus photograph, there is perifoveal graying and right angle bending of vein. On fluorescein angiography in the venous phase, we see that there is presence of tiny microaneurysm-like structures which are telangiectasia, and we see a right angle bending of vein, which confirms the diagnosis of perifoveal telangiectasia. Here we can see that there is presence of minimal leak from these telangiectatic vessels, but temporarily we see that there is a profuse leak. The profuse leak in PFT can be due to subretinal neovascularization, which is a complication of PFT. But it may not be always possible to identify the neovascularization on fluorescein angiography, and OCTA really has a better advantage in picking up these neovascularization. Coats disease. In Coats disease, we can see that there is presence of telangiectasia aneurysms, which are typically described as light bulb appearance, a peripheral non-perfusion areas, vascular communicating channels, and profuse leak in late phase. One thing we need to understand is, as Coats disease is predominantly affects the kids in first decade, it may not be easy to do angiogram, and a red cam would be helpful in very young kids, and a wide field angiography is a better tool for diagnosis of Coats disease. Here we can see that there is presence of telangiectasia, which is the typical, and aneurysms, which is typically described as light bulb, presence of peripheral non-perfusion areas, presence of vascular intercommunicating channels and leak in late phase. So coming to papilledema. So in papilledema, in venous phase, we see dilatation of pre and peripapillary capillaries, and in late phase, we see profuse leak. It helps in distinguishing pseudopapilledema from papilledema. In pseudopapilledema, we don't see the profuse leak and pre and peripapillary capillary dilatation. Ischemic optic neuropathy. In ischemic optic neuropathy, in fluorescein angiography, we see that there is hypoperfusion of disc vessels. There will be segmental ischemia and associated hypoperfusion of choroid in the corresponding sector. Here we can see that the nasal choroid is showing hypoperfusion. So it can be helpful in confirming the diagnosis and to differentiate the ischemic optic neuropathy from papillitis. In ischemic optic neuropathy, we see that there is hypoperfusion of disc vessels and segmental ischemia, whereas in papillitis, the disc will be hyperfluorescent and shows profuse leak. Moving on to inflammatory disorders of the retina and choroid. Coming to white dot syndromes. For the easy understanding, except multiple evanescent white dot syndrome, all other white dot syndrome exhibit early hyperfluorescence with late staining. Whereas in multiple evanescent white dot syndrome, we see early phase hyperfluorescence and late staining in a wreath-like appearance. The indications are to confirm the diagnosis and to identify choroidal neovascularization, which is a known complication of white dot syndromes. So this is an example of acute posterior multifocal placoid pigment epitheliopathy. Here we can see that in the venous phase, there is presence of hypofluorescence, which is placoid in shape, which is mainly due to choriocapillary ischemia. And in the late phase, the corresponding areas of hypofluorescence show hyperfluorescence. Whereas this is an example of multiple evanescent white dot syndrome, in which in the early venous phase, we see presence of punctate hyperfluorescence, which is arranged in the form of wreath. And we can see that in the late phase, there is staining. Here we can also see that there is presence of disc leak in mutes. VKH disease. In VKH disease, in the early phase, we see multiple hypofluorescent placoid lesions, and in the late phase, we see leak and pooling of dye in neurosensory detachment. Coming to active vasculitis. On fundus photograph, it appears to be that we can see that there is presence of a few exudates in the perivascular area. In fluorescein angiography, we can well make out that there is presence of perivascular leak. Here we can see that the intensity and size of hyperfluorescence is increasing in the late phase, suggestive of perivascular leak, and it confirms the active vasculitis. Whereas in resolved vasculitis, the role of fluorescein angiogram is, here we can see that there is presence of extensive hypofluorescent areas due to non-perfusion, and it also helps in identification of a neovascularization and helps in guiding the laser photocoagulation in patients with resolved vasculitis. Moving on to tumors. Retinal capillary hemangioblastoma. In retinal capillary hemangioblastoma, in early phase, we see intense hyperfluorescence. In late phase, we see leak or staining. The clinical utility of fluorescein angiogram in retinal capillary hemangioblastoma is identification of small tumors which can be missed on clinical examination. Here we see that this is probably the area which has this small retinal capillary hemangioma, which was missed on clinical examination. Cavernous hemangioma. So cavernous hemangioma, the characteristic fluorescein angiographic characteristic is presence of fluorescein cap. This characteristic feature is because in this saccular dilatation, the cellular components of blood, such as the white blood cells and the red blood cells, settle inferiorly, and the upper part of the saccular dilatation has plasma. The fluorescent dye usually flows through this plasma, so it's seen as a fluorescent cap, and the lower half is seen as a hypofluorescent area. So it's a very characteristic feature. So the clinical utility is that in patients, it's very rare for a cavernous hemangioma to show bleed, but in cases with bleed, a fluorescein angiogram can help in detection of fluorescein cap and confirm the diagnosis of cavernous hemangioma in such doubtful cases. Choroidal hemangioma. In choroidal hemangioma, in early phase, we see hyperfluorescence corresponding to the tumor, and in late phase, there is an increase in intensity of hyperfluorescence. If there is presence of neurosensory detachment, we see pooling of dye. Choroidal melanoma. In choroidal melanoma, fluorescein angiography demonstrates the intrinsic vascularity, which is typically described as dual circulation. That is, the retinal circulation and the tumor circulation both can be seen on fluorescein angiogram. To summarize, you have to use the angiographic terms accurately. You have to interpret each lesion before reaching a conclusion, and we always have to interpret the case with the background clinical information. Just by looking at the fluorescein angiogram, it's not always right to come to a conclusion. We should have a background information to come to a conclusion. So, like in the last class, we discussed like if there are any students in the hot seat, they can read the fluorescein angiography images.
Sony, you would like to do that?
Yes, sir. Good evening, sir.
Yeah, anybody in the Sony, please read that.
Yes, sir.
Just put on that, Dr. Pradeep. Yeah. So we have, you see, color photograph here and the two angiograms. So kindly read.
Sir, this is the left eye of the patient.
Very good.
In the color photograph, we can see hard exudate surrounding the macula.
Okay.
And
so the predominant finding is there are hard exudates in the posterior pole. Yeah.
Yes, sir. And the vessels are looking tortuous. In the fundus fluorescein angiography, we can see microaneurysms surrounding the foveal avascular zone, and which in the late phases we can see leaking from the.
So my suggestion, Sony, is don't jump to micro. You say they because read like a angiographer that there are in the first picture here there are dot hyperfluorescent spots there. Yes. Don't jump that they are microaneurysms or this thing. So you say there are hyperfluorescent spots visible in the macular area, which on the late phase show increase in the intensity and there is some leakage also because the size has increased. They have become blurry and they have become coalescent, suggestive of a leakage there.
Okay, sir.
We can also include like which phase of angiogram this would be. That would...
Very important. Because if all the veins are filled up, so Sony, which phase should it be?
Laminar flow, early venous phase, and this is the late venous.
So laminar flow, yeah, you can, because in the inferior part maybe, but it's a predominantly, I think, early venous phase only, venous phase. And the second one is the late venous phase.
Late venous phase.
So like Pradeep was saying, don't jump to anything. Always have, the color picture, and then I do not see there's a lot of tortuous vessels are here.
Yes. Sir.
Vessels look by and large, see straighter. Because once you say they're tortuous vessels, that means you are trying to guide the examiner that you may be dealing with a vascular block.
Okay, sir.
No, Pradeep?
Vessels here show tortuosity, but the major vessels doesn't show any significant tortuosity.
Yeah, I agree. The vessels here do show, you see some tortuosity, but
distortion of foveal avascular zone.
Yeah. On the color picture, yes. And even in F-ray also, I agree.
I think the description should start which eye you are reading the angiogram, and then stage of the angiogram, the media clarity. Then you should read about the disc, how is the disc findings. Then go to the vessels, both temporal vessels and the rest of the vessels. Then come to the macular center, any abnormality is noted or not. Then you go to the periphery or whichever areas which are seen on the angiogram, whether there are any abnormalities. While describing, you should also say whether it is hypofluorescent areas, hyperfluorescent areas, and any other additional findings. Okay, whether it is blocked fluorescence, vascular means if you are seeing microaneurysms, then what type of vascular hyperfluorescence it is associated with, or vascular hypofluorescence which is associated with, like capillary non-perfusions and all. It should be a little bit more descriptive so that it will be the examiner or the person who is listening to you will understand that you are more learned than anything. Certain times we may on angiogram may go on the wrong on diagnosis, because alone angiogram you cannot interpret. You should always interpret in conjunction with the color fundus photograph, and probably a little bit of more history and everything can help you in more.
So it is important that you see, follow a sequence like
Yes.
Dr. Ajit was saying, like start from the disc, vessels, then general surface of retina, and mid periphery or whatever periphery is visible. So if you follow that sequence, you are unlikely to miss any finding. You see, it's not important to jump to a conclusion about the diagnosis. What is more relevant is to pick up the finding of the disc, vessels, and the structure of the. Any other angiogram you have, Pradeep?
Sir.
For anybody else to read?
Yes, this is
Anybody
very
else?
good.
Let us hear from Christy.
No, Christy, she will not take to this. Any other hard hit candidate?
No,
is there?
I was saying Christy can ask. I don't see any. I don't see any other person in the view. I can't. Anybody else? Can you tell?
Yes. You want me to read? So
No. If anybody else, let them get the preference. In the hot seat.
Any hot seat candidate?
Unfortunately, only Soini is there.
So there's no harm. I can also read. There's no issue about.
But yeah, let's only attempt one more time, because this is more interesting than the previous angiogram.
So let's Sony try again. One more read.
Sir, this is the right eye fundus photograph showing tortuous vessels, and there is.
So other thing you should say is tortuous vessels in virtually all the quadrants. You see upper temporal, lower temporal, upper nasal, all vessels are tortuous.
In all the quadrants, cotton wool spots involving both superior and inferior fields, and there is hyperemia of disc, maybe suggesting neovascularization.
Just limit yourself to hyperemia.
Okay.
Don't jump.
Not only hyperemia, if you are seeing the disc, whether the margins are clear or not.
No, the margins are not clear.
You describe that.
So you say nasal margin is clear, but temporal margin is not.
Temporal margin is not.
And it's tortuous veins. The arteries are not tortuous. That again.
Yes.
The veins are venous tortuous. Yes.
These are the arteries.
Arteries, actually, there is a narrowing of the arteries actually.
Yes. Also comment on AV ratio then also. Because normal AV ratio is say 2:3. Here arterioles are narrowed and veins are dilated and tortuous. So maybe it is 1:4 or what.
And coming on to the first angiogram.
Yeah, Sony, let Sony describe.
Sir, altered foveal contour also in the color fundus.
No, what Ajit Babu said. What Ajit said. Start from the disc, vessels, and rest of the retina. Don't jump to fovea.
Okay, sir. This is the right eye fundus fluorescein angiogram. In this, we can see the veins are dilated, and this is early arterial phase. The arterial veins are not perfused still.
So Pradeep has written 32S there. Okay,
32 seconds. Last class, were you there? No?
Yes, sir.
Yeah, you are there. Then 32 seconds. What do you expect on fluorescein angiogram?
It is the last. It's the complete.
By that time,
Last
recirculation will start.
recirculation will start.
Yes.
Yeah.
So what phase is this angiogram showing you?
Sir, washout.
What washout? That
Choroidal.
is late phase. No,
Yeah.
but the middle one he written 32 seconds, right?
Yes, sir.
So what is happening to this angiogram? What is happening to the eye? The dye entry and everything.
The dye is showing stasis in the arteries.
No, see, 32 seconds you are expecting a recirculation phase. But what phase is this angiogram of this eye showing? You just described. You are right. Only thing is you require a little bit of clinical application.
Not able to tell, sir.
Oh, you are in arterial phase, whereas the timing shows that it should have been in recirculation phase.
Yes.
So
Sir.
there is a delay in passage.
Delay.
Okay.
Significant delay in passage of the dye.
Okay, sir.
Retina circulation time. How much is it?
Yeah.
It's about 12
25
seconds.
to
It's
30.
about 12 seconds.
10 to 13, 15, don't worry.
So there is delayed.
Yeah.
We need to know
So
whether
we
it
say
is
till
just a delayed arterial filling
I need
or
to,
a delayed arteriovenous filling also.
Yeah.
I need
But
to-
there is a definite delay in the venous
Yeah.
filling. तो बहुत delay है ना?
Yes. Yes.
I would like to clarify one thing. Usually, if we place the cannula in the antecubital vein, that 10 to 15 seconds will be valid. But this was performed, and when it was performed, the cannula was in the wrist. So
Yeah.
this will be a bit delayed. Even in a normal patient, it will be a bit delayed, sir. When we
How
do.
much? Pradeep,
But that's
how
a very
much
small.
delay
That's
would
that
it
is small.
That
Yeah,
delay will
very
be about
small.
2-3
It
more
is
seconds.
not 10 seconds to 32
Yeah.
seconds.
Yeah, it would not be this much more, yes, sir.
That's what
That's a very subtle quiz question, but not for not for this angiogram. If at 32 seconds it is showing veins still not filled up, we say there's a definite delay in the filling of veins. Definite delay. ठीक है ना? What next, Soini?
Sir,
How is the foveal avascular zone?
sir, the distortion of the foveal avascular zone.
It's very difficult to comment. We can't.
Yeah, comment. It's difficult to comment because there is no perfusion at all of the cap. Arteries not fully filled. Even now, if you see with enlarged picture.
Here we can see that beyond this, the arteries are not completely filled.
Yeah.
Okay, sir.
So it's difficult to comment on foveal avascular zone until there is complete arterial filling and it's past the AV transit, AV phase. After that only we can actually comment on foveal avascular zone. In an arterial phase, we cannot comment on foveal avascular zone.
Rather, you can say in this frame, I cannot comment on the foveal avascular zone.
FZ, yeah.
Okay, sir.
What about the second frame? The late.
Yeah.
There is pooling of.
Not pooling. So what you can describe it? What has happened over here? What you see? What is this actually? What are these?
Sir, microaneurysms.
No, you don't see microaneurysm should have been seen in the early phases. If you don't see microaneurysm phase, here we can see that there is presence of hyperfluorescence, which has significantly increased from the previous. If we compare from here, there is an increase in intensity and size of hyperfluorescence.
Exactly.
And we can see that
instead of commenting specific lesions like microaneurysms or anything, you say areas of hyperfluorescence are observed in the macular area.
Okay, sir.
Probably.
Fuzzy margin is indicative of
with fuzzy margins. Yes.
and few blocked fluorescence around the disc.
Disc margins are also blurred with multiple areas of hypofluorescence, which possibly a blocked fluorescence.
Okay.
Right?
Sir. Okay.
If
Sir.
you have the color fundus photograph beside, then you can say it's blocked fluorescence. If you see the hemorrhages, sir.
Okay. Sir.
Yeah, go ahead.
So any clue from treatment point of view? This is diagnostic. I think you have done a reasonably okay job. I won't say that bahut acha pad diya, but still what you have ultimately concluded is there's a delay in the filling of both arteries and veins predominantly, and on the late phase there's a posterior pole leakage there.
Okay. Sir.
Okay.
Okay.
So this is ultimately is the any therapeutic point of view in case, because this does not show, as Pradeep had shown, any neovascularization here in at least in this frame. Does not show any neovascular component. So this patient may not, as of now, although the superior parts, above the arcade show some non-perfusion here, but there's no obvious neovascularization. That means is not an immediate candidate for aggressive PRP. So this patient, we would like to see an OCT to have, documentation of macular edema, and maybe require an anti-VEGF rather than jumping to, like he was saying, showed one patient of CRVO where there was intense ischemia. So intense ischemia means that this patient may require an aggressive scatter laser photocoagulation. और प्रदीप और है आपके पास? So this is very good. This is very good. You see, this diagnosis, I think I would prefer from Sohini or anybody else. What does it show? Very classical picture of entity. Very classical.
Very good. I think it should be other candidates on hot seats. At least 2, 3.
रोलिका और कोई है वहाँ पे?
Sir, they did not join today. We have been in the group. Yeah.
Okay. So we all can describe, no issue. You can start, no issue. So I used to carry angiograms, you see, in 80s to all these conferences and padho bhai kya hai.
Yeah.
Like the color photograph here shows around the disc there are some tracts here, gray colored tracts, some running parallelly, some running circumferentially.
First of all, the disc margins are very clear, and there are multiple brownish color tracts are there with which is extending both superiorly nasally as well as temporal to the disc, superior temporal to the disc. The superior temporal tract is extending through the macular area to inferior, while the areas in the macular area as well as in the inferior temporal areas, it is associated with some hemorrhage in the around the tract.
Christy can answer. She had retina thesis. Christy.
No, I think there's no harm. No harm. No harm.
They are co-hosts, so we should respect them.
Yeah. No harm. Anybody reads. I don't mind anybody.
No problem.
Yeah.
I guess.
Yeah, go ahead.
No
Okay.
Yeah.
If besides the disc findings around the disc, otherwise it looks like a acute and chronic CSC.
Oh,
don't jump at all.
I can tell you the diagnosis, but I am describing each one very clearly.
Christy and everybody, I hate all these things that you jump to diagnosis. Don't become a super consultant, I'm telling you. That is where we all commit
diagnosis. Do you think I don't know the diagnosis here?
Diagnosis, Ajit Babu knows. You see, if I say this is a patient of angioid streaks and there is a patient who
CRVM is there already.
So this is not CSR.
Yes.
Okay, I was
It's
just
angioid streaks, very classic angioid streaks with
Okay.
NVM. But there is a way to describe, and you should see all those lesions which are very clearly, very elegantly shown.
okay.
Early angiogram, if you see the first picture,
Yes.
yeah.
So I appreciate the way Ajit Babu said in the beginning that if don't become super, start the disc, surrounding area, vessels, macula, general retina. You will not miss, because if you see around the disc what he was describing, that
Yeah.
there are this pigmented kind of tracts, and one of the track is running across the macula, and there is a subretinal heme here. So that is
Yeah.
good enough. You see these tracks and subretinal heme points towards some kind of angioid streaks, which we'll discuss about, say, Paget's disease or so many other diseases. And if you see the fluorescein angiogram, the three phases which Pradeep has shown from early to late, you see there is an increase in the hyperfluorescence here, which is suggestive of CNVM. So this tracks and CNVM points towards a diagnosis, most probable diagnosis of angioid streaks in this patient.
Okay.
So don't jump identification of CSR.
Yeah.
So for all this lecture, what you see Pradeep has labored so much goes waste. So please don't jump to diagnosis.
Okay.
And if you see the three angiograms, when you are examining and describing three angiograms, it should be described serially. If you see the tracks which is bisecting the macular center, it is hyperfluorescent, associated with the hyperfluorescent areas exactly on both the sides of the macular center, and inferior tract also is associated with halo of hyperfluorescence in the first picture. In the second picture, the hyperfluorescence is increasing and it is with fudgy margins. And the inferior, the hyperfluorescence is remained as it is, and there is slight increase in hyperfluorescence, but it is not drastic increase in hyperfluorescence.
Yeah.
Whereas if you follow the same angiogram in the third picture, the hyperfluorescence has increased a lot with increased fuzzy margins.
Yeah.
So that is what that is indicative of CNVM.
Neovascularization.
Okay.
You should say this is characteristic of neovascularization. Most probably in the location you are seeing, it could be a choroidal neovascularization. With the tract lesions, it should be a streak.
The streaks, angioid streaks.
And streaks with choroidal neovascularization.
Yeah.
So I think time is not on our side, Ajit. In fact, Ajit, I have heard his. Can you stop, Dr. Pradeep? Yeah. So because time is not on our side, I have heard Ajit Babu's talk on angiography, and I myself have and Gopal. Everybody has huge number of angiograms, and Ajit Babu loves to teach angiography. The way he has mentored today, I think hats off to him by not forgetting to tell how to read. And please don't jump to any diagnosis. Otherwise, this whole effort, what Dr. Sagar did, will go waste. Don't say that it is micronism. Don't say that it is CSR. Unless and until you're asked what is the most probable diagnosis, then it's okay. But don't jump to it. So we will love to thank Pradeep Sagar for very nicely illustrating. And the most happiest moment of my today's this thing was that he brought a couple of angiograms for even mentored to elucidate what it is. But to conclude, I'd just like to say, please go back and read, study, and listen to YouTube again and again, and we'll wait till the time Santosh has those physical workshops where Pradeep can bring in a lot of angiograms, and then we can read. But suffice to say, do not jump. You should comment on a good FA, media hazy or not. Never interpret on one frame. Never interpret on one frame. You should have at least sequence of frames. And the beauty of angiogram over all these other techniques is that it provides wealth of information in, say, 5 to 7 minutes. You see, Pradeep showed very wonderful, subtle neovascularization. No amount of diligent examination, 90D, inter-D, will not pick up those subtle angiomas, what he showed, or subtle neospallation. But in 5 minutes, angiography will show by neospallation. So wealth of information comes in 5 to 7 minutes. And always don't jump and correlate clinically. You see, have a color picture and then start commenting. Like Ajit was saying, blood fluorescence, so you have to have a color picture there. And he described a lot of entities, OIS, diabetic retinopathy, vascular. I'm sure you see a lot of other entities are also there. Last comments from Professor Gopal.
Yes. Gopal is silent.
No, Gopal,
No,
because
in front of my teachers, actually, Lalit sir has been a mentor and teacher and guru for me. And through the years, I've seen Ajit Babu sir, I've seen your surgery, I've come to see your surgery to learn from it. And Santosh also, what all? So when teachers are there, what is there for me to say? I was just hearing you all, that is all.
No, I think Pradeep did a fantastic job. And it's,
Yes.
it's humanly impossible to cover angiogram. I remember, you see, me along with Pradeep and Ritesh wrote one book on angiography along with Dr. Tiwari, and it took how many months for us to write that book. But I'm very happy that Sagar has contributed so much, and I would wish all of us listen, because I also listened to his YouTube, which he did on last Friday, so as to be online. But suffice to say, there are, you see, developments occurring. Octa is picking up. But today, believe me, without angiography, I will not. Without Octa, I may still function. But without FA, I will not start in retina services. That is true. No, Pradeep? Sagar?
Yes, sir.
So still, you see, FA forms a part. And he very categorically said, things like CSR. There are a lot of developments happening, new classifications of CSR, J. Shiblani has given recently. A lot of things are coming up. But FA is important, especially when you're treating. You see, he described after all entities summary that why it is important. So very good things. If you're lasering a patient, you have to have an FA. Suppose you're lasering a focal diabetic macular edema. So you have to have an FA. You can't otherwise. Suppose you are, even example of JFT said. JFT, very good, he said, was Octa is picking up more than the classic FA. But in the end, I just like to conclude by thanking Pradeep and thanking Santosh for bringing Pradeep here and giving such illuminating talk. And although it's an ongoing subject, believe me, Ajit Babu and both Gopal, and they can, talk on FA. And Ajit Babu was a fantastic lecture. He used to give an IC, which I used to conduct, and he used to give FA in disorders. Fantastic lecture he has. Maybe sometimes we will listen to his lecture also. So with these words, Santosh, we conclude and thank everybody, especially Sunil for being in
We
time.
invite everyone for Friday's lecture. That will be on ICG angiography by Dr. Devamalya Das.
Yes,
Thanks
sir.
a lot. Thank you. Thank you, everybody.
Thank you, sir.
Bye-bye.
Good
Bye,
night.
Gopal.
Bye, sir.
Thank you, Pradeep.
Thank you, sir.
Thank you, Rolika. And
Yeah, Pradeep, thank you, Gopal.